Hi everyone, welcome to our channel, Canadian Nurse Expert. Are you preparing for a nursing exam? Let's discuss a crucial exam topic. What is prioritization of care? Let's break it down. Alright everyone, let's talk about something that sounds super complicated but is actually our nursing superpower, prioritization. What even is it? Well, imagine you've just started your shift. You've got 4 patients, and suddenly all their call bells go off at the same time. One person needs help to the loo, another is asking for a cup of tea, a third says their pain is a 10 out of 10, and the fourth is gasping for breath. Who do you run to first? That, my friends, is prioritization. It's the art of figuring out what is most important and what needs your attention right this second. This skill is literally what keeps our patients safe. It's not about who is the loudest or who has been waiting the longest. It's about looking at the entire situation and deciding which patient's problem is the most life-threatening or could get worse the fastest. The NCLEX absolutely loves to test this because in the real world, you are constantly juggling tasks. You're a professional plate spinner. Mastering this skill means you can provide safe and effective care, even when everything feels like total chaos. It's about using your critical thinking to protect your patients from harm. Think of it like this. Your nursing license is basically a license to think critically. You're not just following a to-do list, you're constantly assessing, reassessing, and shuffling your plan. Prioritization is the framework that helps you make those decisions logically, instead of just guessing. It's about knowing the difference between a problem that needs immediate action and a problem that can wait a few minutes. Getting this right is what separates a good nurse from a great nurse, and it's the key to walking out of that NCLEX exam feeling like you've absolutely smashed it. So, how do we do it without having a complete meltdown? Luckily, there are some brilliant tools to guide us. These aren't just random rules. They are tried and tested methods that help us make sense of the madness. We've got our ABCs for emergencies, Maslow's hierarchy for everything else, and a few other clever tricks up our sleeves. By the end of this, you'll be able to look at any NCLEX question with multiple patients and know exactly who to see first. Let's get into it and make you a prioritization pro. The ABCs, your life-saving best mates. First up, let's talk about the absolute foundation of all prioritization, the ABCs. This is your go-to framework in any emergency. It stands for airway, breathing, and circulation. These 3 things are essential for life, and if any of them are compromised, your patient is in serious trouble. Always, always, always start here. Nothing else matters if your patient can't breathe. This is non-negotiable, both on the NCLEX and on the ward. It's the golden rule of patient safety, so drill it into your brain until it's second nature. Let's start with A for airway. Is the patient's airway open and clear? If not, nothing else you do will work. Think about a patient who is choking on their food or an unconscious patient whose tongue has fallen back and is blocking their throat. Another classic example is a patient with anaphylaxis, where their throat is swelling shut. These are airway emergencies. You must intervene immediately to clear the airway. This is your #1 priority, every single time. Without a patent airway, oxygen can't get in, and that's a game over situation. Next, we have B for breathing. Okay, so the airway is clear, but is the patient actually breathing effectively? This is about the process of respiration itself. A patient having a severe asthma attack is a perfect example. Their airway might be technically open, but their bronchial tubes are so constricted that they can't move air in and out properly. Another example is a patient whose respiratory rate has dropped dangerously low after receiving too much morphine. They aren't breathing enough to get the oxygen their body needs. This is a huge red flag that requires your immediate attention. Finally, we have C for circulation. If the airway is open and the patient is breathing, we then check their circulation. Is blood getting around their body to deliver that precious oxygen? Think of a patient with a dangerously low heart rate and blood pressure, or someone who is actively hemorrhaging from a wound. Their circulatory system is failing. A patient having a heart attack fits right in here too. Their heart muscle isn't getting enough blood, which affects their entire circulation. These are critical situations where you need to act fast to restore blood flow. So, what happens when none of your patients has an immediate ABC issue? What if everyone is breathing just fine? This is where our next amazing tool comes in, Maslow's hierarchy of needs. This is a pyramid that organizes human needs from the most basic to the most complex. For nursing, we use it to decide what to prioritize when the situation isn't a life or death emergency. The rule is simple. You always have to meet the needs at the bottom of the pyramid before you can even think about the ones at the top. The very bottom level of the pyramid contains physiological needs. These are the things humans need to physically survive. This includes air, water, food, sleep, warmth, and for NCLEX purposes, pain relief. If a patient is in severe pain, that is a physiological need that you need to address. A patient who is dehydrated because they've been vomiting all day has an unmet physiological need. These are almost always going to be your priority over needs that are higher up on the pyramid, assuming there is no ABC problem. The next level up is safety and security. This is about making sure your patient is safe from harm. For example, a confused patient who is trying to climb out of bed with the side rails down is a major safety risk. They could fall and break a hip. Helping this patient is more important than, say, teaching another patient about their discharge medication. A safety need, like preventing a fall, trumps a need for education. You have to ensure the patient is physically safe in their environment before you can move on to other things. Now let's compare these to the needs higher up the pyramid, like love and belonging or self-esteem. Imagine you have two patients. Patient A is that confused person trying to get out of bed. Patient B is feeling lonely and wants to talk about their family. According to Maslow's hierarchy, you must go to patient A first. Their need for safety is more urgent than patient B's need for love and belonging. It's not that patient B's feelings don't matter, but preventing a physical injury takes precedence. Master this, and you'll find those tricky prioritization questions much easier. Beyond the ABCs and Maslow's, there are a few more quick and dirty rules that will help you ace those prioritization questions. One of the biggest ones is choosing between an acute problem and a chronic problem. An acute issue is something that is new or has suddenly gotten worse, while a chronic issue is a long-term condition that the patient lives with. You should always prioritize the acute problem. For instance, a patient with chronic asthma who has their usual wheeze is less of a priority than a patient who suddenly develops chest pain for the first time. New symptoms are scary. Another key principle is prioritizing actual problems over potential problems. An actual problem is something that is happening right now, whereas a potential problem is something that might happen. Let's say you have one patient with a surgical wound that is actively bleeding through the dressing. That's an actual problem. Your other patient is at risk for developing a pressure ulcer, which is a potential problem. You need to run to the patient who is bleeding right now. Address the fire that's burning before you start worrying about fire prevention. Then there's stable versus unstable. This is a huge one for the NCLEX. An unstable patient is one whose condition could change rapidly and unpredictably, often with a risk to their life. A stable patient's condition is predictable, and they are not in immediate danger. For example, a patient with a blood pressure of 80/40 after surgery is unstable. A patient who had the same surgery yesterday and has stable vital signs is, well, stable. You always see the unstable patient first. Their condition is the most volatile and requires your immediate assessment and intervention. Finally, let's not forget our good old nursing process. ADPI, assessment, diagnosis, planning, implementation, evaluation. When you're stuck, think about what you need to do first. More often than not, assessment is the first step. If a patient's condition is changing, you need to assess them before you can do anything else. For instance, if a patient reports feeling dizzy, your first action is to assess their vital signs. You need that data before you can decide what to do next. Assessment always comes before implementation, unless the situation is so critical that you have to intervene and assess simultaneously. Let's put all this theory into practice with a classic NCLEX-style scenario. Imagine you're the nurse on a busy surgical ward, and you've just received the handover report. You have 4 patients. Who do you need to assess first? Take a deep breath, and let's work through this together. We are going to use our prioritization frameworks to find the right answer, just like you will on exam day. Remember, the goal is to find the patient who is the most unstable or has the most immediate threat to their life. Here are your patients. Patient A, a 55-year-old man who had a knee replacement yesterday. He is reporting pain of 8 out of 10 in his knee. Patient B, a 62-year-old woman who had an abdominal hysterectomy 2 days ago. She is asking for help to get up and walk to the toilet. Patient C, a 34-year-old man who had his appendix removed this morning. He is now reporting feeling short of breath and restless. Patient D, a 70-year-old woman admitted with a chronic obstructive pulmonary disease exacerbation. Her oxygen saturation is 91% on 2 liters of oxygen, which is her baseline. Now let's analyze this using our skills. Patient A has a high pain score. This is a physiological need according to Maslow, so it's important. But is it life-threatening? Not immediately. Patient B has a need for assistance, which falls under safety. Also important, but not an emergency. Patient D has COPD and a slightly low oxygen saturation. But the key word here is baseline. This is her normal state. She is stable. We need to keep an eye on her, but she isn't the priority right now. That leaves us with patient C. He is a post-operative patient who is suddenly feeling short of breath and restless. What do these symptoms scream? They scream potential pulmonary embolism, which is a massive ABC problem. Shortness of breath is a B issue, breathing, and it's a new acute change in his condition. This makes him the most unstable patient on your list. His condition is a direct threat to his life and requires immediate assessment and intervention. Therefore, you must see patient C first. This is a perfect example of how the ABCs will always trump everything else. Thank you for watching. For more videos on NCLEX-RN preparation, visit Canadian Nurse Expert.